Good morning. Welcome to Systematizing Diversity, Equity, and Inclusion into Lean Practices with Nate Higbee and Shauna Whipple. I'm Jessica Dang with Results Washington. My pronouns are she, her, and I'll be your moderator today. We have about 1,000 of you registered for this session, and we are so happy that you are here. I'm joined today by Melissa Shaw, who will be providing ASL interpretation today. And thanks to my teammate, Ali, who's managing technology behind the scenes. I want to share a few things before we get started today. Many of you are familiar with Zoom meetings, but there are some differences in Zoom webinar, which we are using today. The biggest difference is that you won't be able to talk or have your video visible. This ensures everyone can pay attention to the presentation today. We want to draw your attention to a few different features in Zoom. Notice the Zoom toolbar, move your mouse, and the toolbar will appear, and you can see the icons for chat and Q&A. Chat isn't available for an exercise today. This is a public record, and we won't be monitoring it. Chat between participants is not available during this session. There is a handout, which we will be posting in chat soon. For Q&A, feel free to pop questions into the Q&A feature at any time. And hopefully there'll be some time at the end of the session where Nate and Shauna can take your questions. Next, you'll see the icon for closed captioning. If you wish to see closed captioning, select that icon and select View Full Transcript. You can also adjust your screen view by sliding this vertical bar from left to right to adjust the size of the presentation today. Session materials are available on our website, and the videos will be up within about a week. If we get disconnected or run into technical troubles, we'll try to get the webinar back up for about 5 minutes. In the event we can't do so, we'll record the session and put it up on our website at a later time. Finally, at the end of the session, a survey will pop up. Please take the time to complete the survey. This will provide both the presenters and Results Washington with great real-time feedback. Well, we are so fortunate to have Nate and Shauna with us today. First, a little bit about Nate. He is a Virginia Mason Production Systems Specialist at Virginia Mason Franciscan Health and oversees various quality process improvement initiatives, including work to systematize equity into the management system. In addition to this role, Nate co-chairs Virginia Mason's LGBTQIA+ affinity group, Proudly VM. Outside of Virginia Mason, Nate is a commissioner for the Seattle LGBTQ+ Commission. Nate Higbee holds a bachelor's degree in sociology from Whitman College. Now a bit about Shauna. After spending the 90s as an activist and social worker in Seattle, Shauna Whipple needed a career change. She became a phlebotomist at Virginia Mason in 1999, hoping that poking people with a needle would be easier. When Virginia Mason introduced its new management method, VMPS soon became her passion, her new form of activism. She made the move to become VMPS specialist in 2008 in the Kaizen Promotion Office and has been there since. Welcome, Nate and Shauna.
Thank you, Jessica, for that introduction. And on behalf of Shauna and I, we just wanted to give Results Washington a huge thank you for hosting us and having us attend and present at the conference. And it's hard to believe today's the last day of the conference. And I know many of you probably have learned a lot of great things. And so, it's an honor to be able to kind of wrap up the conference with this presentation and be able to tell you Virginia Mason's story. So today what we're going to do is I'm going to be sharing with you a little bit about our management system and how we started to take a look at our management system with an equity lens. And Shauna is going to take over for the last half of the presentation and talk about some products and tools that came out of our work. And we'll wrap up with a conclusion focusing on what we think are necessary things to keep in mind or to take with you as you start to look at your own lean processes with an equity lens. But before we progress, I just wanted to give you a heads up that Shauna and I are in the same room, so we'll try to be really good about muting ourselves when we're not talking, but apologies in advance if you get a little bit of feedback. So I see. So a little bit about our management system. a little bit about our system, our healthcare system. We were founded in 1920, started off as an 80-bed hospital with 6 physician offices, and slowly grew over time and acquired approximately around 9 regional medical centers situated across King and Kitsap County. At the beginning of 2021, we merged with CHI Franciscan to create Virginia Mason Franciscan Health, a 11 hospital system with 30 sites of care, primary care, specialty, same-day surgery centers. We also have a research institute known as the Benraya Research Institute, Bailey Bichet House, which is a clinic predominantly serving our homeless community here in Seattle, and Virginia Mason Institute. We employ over around 18,000 team members and staff, including 5,000 employed physicians and affiliated providers. So a factor that was largely considered in our decision to merge with CHI Franciscan was our management system. Our management system, as Jessica named, was the VMPS, which stands for Virginia Mason Production System. So the Virginia Mason Production System is really kind of a hybrid of some values from the Toyota production system and elements from the philosophies of Kaizen and Lean. And so while many healthcare systems across the country or across the world have kind of incorporated some elements of TPS into their organizations, such as 5S or WASTE, we were the first organization to fully integrate the TPS management philosophy throughout our entire system, meaning we weren't just focusing on one department or one service line. We were looking at the entire system, our entire organization, through using Lean. And because of our success, we were able to build an external branch called the Virginia Mason Institute, which consults and educates other leaders across different industries on our management system. So as I mentioned, our management system was actually adopted in like 2002, and this was really during a volatile time in healthcare. So a lot of healthcare industries our organizations were seeing decrease in quality, increase in costs, and Virginia Mason was no exception to this. So we, in 2001 or 2, with our new CEO and our board of directors, the board of directors looked at our leadership team and said, who is your customer? Like, who are you trying to serve? And so this question encouraged our Virginia Mason leaders to look for a management method that placed the customer, the quality, and patient safety first. And so this is when we adopted the Virginia Mason Production System. And ever since then, as depicted by this timeline, we've been slowly evolving our management system over time, incorporating aspects such as daily management or cross-functional management. We've also incorporated elements of co-design, which is the idea of designing with your customers in the room at the table with you. So our evolution of our management system has been occurring over time. And as last year and the year with COVID and with George Floyd's murder, there's been a heightened awareness that we need to start looking at our management system from an equity lens and ask ourselves whether we were truly achieving equitable outcomes with our work. Before we dive further into this, I just wanted to share with you some definitions that I think are important for us to move forward with. So many of you probably already know this, but when we grow up, we've been taught we need to treat everybody equally. So that's the idea of equality, right? But when we think about the legacy of structural racism, sexism, any forms of oppression that exist across institutions, we start to recognize that treating everything equally is not going to help rectify those harms. So as depicted by this picture, equality is the sameness, where every individual and group receives the same resources, and it's not always fair if oppressed groups remain disadvantaged. Equity is a measure of fair treatment and opportunities and outcomes across race, ethnicity, gender, social class, and other dynamics. So in order for us to be equitable, we have to provide specific unique resources that support people and communities to be there so that the basic needs are met. So I'm going to turn it over to Shauna, who's going to share with you about why healthcare health equity is important.
So, good morning. This slide shows a lot about money, and we spend a lot of money on healthcare, more GDP than many other countries with some of the worst outcomes. There are a lot of reasons for this, including health equity. More importantly, we have a moral obligation to address inequities. Many of our mission and vision and values claim this as a goal, and in Seattle, this also could be an excellent marketing strategy as it is part of the greater Seattle area culture. By addressing inequities, we could also achieve some excellent cost savings. For example, dental costs are notoriously expensive, with employers providing minimal insurance, if any at all. And according to a 2001 study published in the Journal of Public Health Dentistry, for every $1 spent on water fluoridation, we could save about $38 in dental treatment costs. And that is if the water is safe to drink in your neighborhood in the first place. There are some rural implications as well. Economic infrastructure includes migrant workers and hospitals, which are often the largest employers in that area. This slide shows some Seattle Times data that most of us has heard about, and it regards the profound impact that the COVID pandemic has had on communities of color. It's happening right alongside us, and we have a moral responsibility to see it and to fight it. The impact has not been solely about getting sick and dying at a higher rate, but also the communities are feeling a bigger fallout from the pandemic in a worse way. Record unemployment rates, increasing mental health concerns, and with increased reliance on virtual care, leaving many folks in the dust who don't have access to a computer, an iPhone, or an internet connection.
So in light of increased awareness around health disparities around community, our organizational leaders, identified health equity to be an organizational priority for the year of 2021. And so what's depicted here is the health equity A3. Many of you probably are familiar with an A3, but for those who are not, it's an organized worksheet that guides the problem-solving process. And this is a framework that we've also stolen shamelessly from Toyota. So in this A3, we identify several goals, identifying gaps in care, outcomes, and experiences across patient groups, advancing our recruitment and retention efforts, and expanding partnerships with community groups. Our leadership team knew that in order for us to be successful at achieving these aims, we needed to look at our management system, which is how we do our work, so that we can be successful. And so the team behind the A3 identified a work stream around systematizing equity into our management system. So this is our strategic plan, and I think this picture, this paints a really good depiction of where our management system sits in our organization. We see it as the foundation for all the work that we do. So Virginia Mason Production Systems sits in the bottom, and the idea is that anytime that we do work across our key strategies or foundational elements, we are using our management system. We're using the tools, the methods, the resources that a management system provides us to manage and execute our work. We do this because we put the patient at the top. So everything that we do, we are doing for the patient. This is a slide that kind of breaks down what a management system looks like in action. It's probably similar to many of your own lean practices. In Virginia Mason, we identify problems by going to a Gemba or where the work happens and observing waste and safety concerns. We collect data using patient safety alerts or patient concerns. We do flow mapping, root cause analysis. We take that data, we make it visible for a team to look at that data and generate ideas. They use our tried and true creativity and innovation frameworks. They test these ideas, and while testing, they're thinking about how they can incorporate some of our VMPS tools, such as inspection, stand work, visual control devices, or 5S. Once they've landed on a great product, they're going to take it to the Gemba, they're going to measure it to make sure it works, and they're going to implement if they're happy with the outcomes. They can use some of our tools for that as well. And then we track the measurements over time. Some core principles of our management system is that when we first adopted Virginia Mason, the VMPS, it's been we've been consulted and told that, this is a top-down culture. Your leadership needs to embrace this management system, and it will trickle down as a result. So as a result, we invest more of our training and resources with the more senior leaders. When we do our improvement work, we do 2 to 5 day workshops, full day workshops, where we have our team members step away from their work for the entire duration of the workshop. As a firm believer that our patients need to be designing with us, we also ask patients to step away from their lives to come and be part of our workshops as well. When we do data collection, we often use several rules of thumbs. We do the 80-20 rule when we're looking at data. So we disregard any outliers in favor of what's happening most of the time, because we believe it's most representative of the process. Observations are often done when it's convenient for the team leader or the person gathering the data. So most of the time, data is gathered during weekday shifts. And when we choose our targets, we're choosing from like a menu that's been preset and in place for years. VMPS is a language. So we, as I mentioned, adopted many components from Kaizen and TPS, and there's a lot of Japanese terminology that we use here in this organization. And we might reference these terms because often during meetings or when we're out on the Gemba, and when we use them in front of other people who might not have that training, it becomes a jargon, becomes a barrier to understanding what's being said. So as principals, you can start to see there are some opportunities for some disparities, are some overlooking of experiences of maybe our weekend or night shift team members, our minority patients. So there was definitely some opportunity that we were starting to find. And so a source for an inspiration for us was something called the Racial Equity Toolkit that was created by the Seattle Race and Social Justice Initiative. As a commissioner on the LGBTQ Commission, this is a tool that we're required to use when we think about initiatives we want to start. And so hearing about how this tool is used to foster an application of equity lens prompted us to ask whether we could steal that framework and apply it to our management system. If we could bake an equity lens in a management system, anytime we do our work, we're considering everybody's experiences and perspectives. And so as the organizational president at the time said, if we can bake in equity into our management system, we can use it as a tool to dismantle inequities across our healthcare system, across our different strategies, and really look at most of our work with an equity lens. So it was decided that we would have a 5-day workshop, also known as a rapid process improvement workshop, to start exploring how to systematize equity in our management system. We decided to scope the work of the workshop to that 5-day process. So we were having a 5-day workshop on our 5-day workshop process. And we chose our 5-day workshop to be a proxy for VMPS because the impacts of these workshops are greater. They require more resources across the organization. And those who lead these workshops tend to skew towards more white, upper class, privileged leaders. So in studying the RPOW process, we found that there were 6 components to the workshop process. They are defining the customer and the scope of the event, understanding current situation, defining who's going to be on the team, both the planning team and the team who does the work, who's going to set the goals and targets, the event itself, and then implementation. For this workshop, we focus on just the first 5 cycles of work. And we created fishbones, which I'm going to show you in a second. For each cycle, we identified all the feeders that inform the decisions made in these cycles, and we circulated these fishbones across the organization. We had over 100 people review these fishbones and provide input on what they saw were potential sources of inequities and provided us ideas on how to be more equitable. We circulated these fishbones across leaders, frontline team members, members of our employee affinity and resource groups that consist of BIPOC and LGBTQIA team members. We also circulated these fishbones with external community leaders and experts, including the chief of Renton School District and Dr. Ben Danielson, a local physician known for his work in addressing healthcare disparities. Because we knew that it was so important for us to solicit the opinion of many because our management system impacts everybody, no matter where they sit in the organization. So I'm going to show you the first fishbone. There's a lot happening here, and I'm going to read out loud kind of the key takeaways that we found for each. So it's okay if you aren't able to read these stickies. So the pink stickies are the defects or the opportunities, and the green stickies were ideas that people had for how to address inequities in this cycle. So this first cycle is defining the customer and scope of the work. So when we think about potential opportunities, we think about who gets to decide what areas get to do more Kaizen than others. Sometimes decisions are made based on the incentive of high impact or because they generate more revenue. And so maybe some leaders are going to say, we're going to focus on this area because there's going to be more return on investment than I'm going to overlook this area. Sometimes scope is often limited to what we perceive as having control over. So when we do our scoping, we never really think about what goes on at the patient home, what goes on in the patient's community that might inform the process that we do. We might just stop and start when the patient is on our campus. Oftentimes, the focus of our work can be informed by unchecked implicit biases, even from our executives. And so a lot of people commented that there was no way of drawing attention to people's potential biases, and which may eventually seep into the work itself. We're studying the current state. This was a huge opportunity for us. It was really looking at how are we meaningfully collecting data that is representative of our community. So opportunities include the 80-20 rule of thumb, which I shared with you earlier. By focusing on what happens 80% of the time in our data collection, we overlook the experiences of those that fall within the 20%. So when you think about inequities and making those inequities that are processes visible, by not bringing forward that 20%, we hinder our ability to understand the root causes for these outliers. So as a healthcare system in a predominantly white city, this means that our data could potentially be skewed to represent only the white patient experience. Similar, our practice of using the median in our storytelling to teams can obscure and the experiences of our minority community patients or team members. When we solicit qualitative data from our team members and patients, we often limit our surveys or interviews to English-speaking patients or team members, and often done in a language spoken by the one gathering the data, which again is often going to be an English speaker. So similar to our point about potential biases in those who initiate the work, those who are gathering the data can also have their own biases, which may inform the data that they gather. And when we do our data collection, we're only considering the ones who are our patients, the ones who are our team members, but we're not really thinking about those who want to be our patients, who want to be our team members, and trying to understand what are those barriers that is preventing them from being our patient or a team member. Studying that, so looking at the Kaizen event team, so when we determine who's going to lead these workshops, we required certified leaders in our management system to be able to lead these workshops. And again, they tend to skew towards predominantly white middle class. And when we ask our patients to be involved in our events, we're asking them to be part of the entire workshop. So, which means that we're limiting ourselves in terms of the perspectives and life experiences that we're bringing to the event. Few patients are unable to step away from their lives and volunteer to be with us for a full week. And so as a result, our patient volunteers tend to be predominantly white retired people. And so how do we design processes that accommodate everybody, including a Black single mom or anyone else who might not necessarily be able to step away from their life or their work to be with us? As a healthcare system, in an urban setting, we have a plethora of community resources that we're not leveraging when we're doing our work. And when we think about our team members who make up the event, sometimes our leaders might pick people they already have a good rapport with, are people they see as superstars. And so this might potentially create a situation where we're overlooking those that might be more shy, just or hesitant to speak up. Lastly, as I mentioned earlier, BNPS has been commented to be exclusive. You're using this language that you're teaching the leaders, but you're not teaching frontline team members. So how does frontline team members engage with our management system if all of our education, all of our training is skewed to or designed for our leaders? Setting goals and targets. So a key cycle of work is really trying to understand what's that North Star. What are we trying to aim towards? And if we don't check our biases in the data that we gather, we might be potentially creating targets based on biased data. Team members have asked us to, is there an opportunity to be more deliberate with our target setting and designing them to gear towards benefiting underserved populations? And then lastly, a question was posed around the idea of incrementalism. We believe in continuous improvement and celebrating small changes, but are we moving too slow on certain things? And do we need to move faster? Are we causing harm by not promoting rapid changes as opposed to slow incremental changes? And then lastly, the event itself was the last cycle box we looked at. And what we had talked about for this cycle box was how are we addressing power dynamics that might be prevalent in the team that does the work? So healthcare has been built off of a system that positions the doctor above others. And those power dynamics, as much as we would like to say it doesn't exist, it still exists. And sometimes that can hinder the team from achieving breakthrough innovation. We don't really have processes that are designed for neurodivergent thinkers. We believe in rapid idea generation. We believe in moving fast. Are we really creating an inclusive environment when we follow through on that? And are we thinking about how are we facilitating and is the way that we're facilitating creating more equitable dialogue across our team members? So those were I just painted you just an example of opportunities that we found in our management system. And so now what I'm going to do is I'm going to turn it over to Shauna, who's going to share with you the work that we did in this workshop and some of the outputs that came out of it.
In preparing for the workshop leaders were very deliberate about the diversity of the team. They recruited social workers, people from HR, colleagues from Yakima who worked in the community there, folks who worked at Bailey Boucher House and some patient services and our medical bioethics RN. The first day, we deviated from our traditional RPIW process and spent time focusing on teaching on equity and to ensure that the team had a shared understanding of what the concepts meant and how they played into our management system. And we also modified certain traditional RPAW exercises, which I'll talk a little bit more about in a minute, to include components of equity. One example being the airplane exercise traditionally used to teach components of flow on day one. And because the event was focused on how we do improvements in the organization, we were easily able to start testing ideas and tools immediately after conception to see whether they had the intended effect. Because of the vast amount of opportunities identified prior to the event, the team was extremely prolific in the number of tools and processes produced during the event. Due to the vast amount of outputs from the event, we had to really phase our implementation efforts, starting with the interventions we believed had the biggest impact on our goals first. The equity pauses and the use of the wastes of an equity wheel. Some of the other interventions to be tested later in phase 2 included updating our standard operations tools and expanding our 5S achievement grid, and then finally, developing an equity learning menu. So now I'll take a few minutes to drill down into some of the products with you. So one of my favorite creations was the inequity waste wheel. And this can be used in any area to improve the visibility of inequities, including systemic racism, so that we can identify and tackle them. It's important to make them visible. We use it to assess processes, policies, and programs through the lens of equity. The development of this waste wheel was largely influenced by how we already conceptualize waste in our processes. We're used to using the traditional waste wheel and information waste fan as we study standard operations and to help users visualize, analyze, and pinpoint where the wastes are in their processes. In this waste wheel, there are two different types of wastes. The violet hexagons are common inequities experienced by people without power and privilege, and they involve things like underrepresentation, mistrust, and access barriers. The blue elements depict behaviors exhibited by those who have the power, such as silencing, assumptions, and power and privilege. And these often are exhibited through our unconscious biases. We use it just like the good old-fashioned waist wheel, where you go out to the gemba, you observe with big eyes, big ears, and a small mouth. And this has been incorporated into our VMPS curriculum as well, and is being added to our new hire orientation. Another highly effective creation is the equity pause. And in just a minute here, we're going to practice it, and we're going to ask you to participate in the chat function. We're going to take a small pause here in a minute. This was largely inspired by the work that local healthcare leader, Dr. Ben Danielson, did with Seattle Children's. And we've stolen the idea of the equity pause and made it our own. And as a side note, we're all big fans of his here. There's a lot of power in just being able to pause and reflect. There were two frameworks around this that were built. One is for the spontaneous equity pause, which is a way to address inequities as they manifest. An example would be stopping the line to address inaccessibility of our mobility challenged patients to our COVID-19 vaccine clinics. Another framework is for the planned equity pause. The team built a toolkit that our leaders can pull prompts or exercises to run through with the team during meetings or events. Leaders and team members are asked to connect equity to their work or the work of their event. The planned equity pauses are now built into our improvement event planning processes by making them standard during all planning meetings, as well as daily during the workshops themselves. The equity pause toolkit makes information easy to access and guides the facilitator. It offers a whole array of topics and exercises to choose from, like a menu. Topics include diversity, inclusion, implicit bias, awareness, speaking up, psychological safety, racism and anti-racism, and health equity. Some recordings were also created to use as examples. The pauses have been tested in multiple settings and not just on formal improvement workshops. We also have a week-long leadership VMPS training that all leaders go through, and they each get a turn to facilitate an equity pause in the class to develop that confidence and that competence. The equity pause is about facilitating a conversation. It's not about knowing all the things and lecturing about all the stuff. You don't have to know all the things to facilitate a successful pause. So now we're going to do a quick, simple example of an equity pause by asking you to respond in the chat. And here's the question. Just share one area where you have some equity opportunities within your management systems. And I'm going to pause just for a few minutes here while we look over some of your responses. Hiring, that's a good one. Ooh, hiring's there. KPIs, selecting people, promotions, performance assessment. Oh, these are excellent. Pay equity, that's a good one. Delivery, okay. Who we serve, training opportunities, workload distribution, mentoring. Oh, those are all excellent. Y'all are very, I'm really happy to hear you already thinking about places to apply these. Executive leadership. Okay, anyway, so we hope, I'm going to move on now, and we hope that this presentation today can give you some ideas of how to apply some of these tools or methods when you're thinking about your work. So the team also wanted to build something that a person could experience while walking in their shoes. On the first day of every week-long improvement workshop we have the team go through a flow exercise where they typically would build paper airplanes. And this is so that they can see and feel firsthand how the application of our management system methodologies improves flow, reduces burdensome work, and tackles bottlenecks. The event team modified the instructions for the airplane exercise by adding elements of disadvantages and advantages. For example, one operator may be asked to use one hand only while folding, while another may be assigned an additional operator for support for a very simple task. We've also called out presenting standard work in a different language, adding mobility challenges, and using iPhones to help facilitate the work. The team then uses the VMPS tools and methods to not only address inefficiencies in the flow, but also inequities in the system of the paper airplane building. The team also made a design change for our 5S achievement grid. Prior to the event, one of our foundational improvement methods had been the 5S's: sort, simplify, sweep, standardize, and self-discipline. The team felt that it was necessary to add a 6th S to the tool, which stands for safety. Now, this isn't a new concept for some companies, as their 5S framework already includes safety. But what's new about this is that it highlights not just physical, but also emotional and psychological safety. Built into this tool are equity pauses, protocols for patient safety concerns, and ensuring that we're considering differently abled folks when we're 5Sing a space or any process that involves motion. And we typically use this achievement grid in 2 main ways. We might use it as a before and after tool for assessing a process, information flow, or a space improvement to help us with measurement. We want to make sure that our intervention actually improved. Another way to use this grid is as a guide while you're team leading, while you're facilitating improvement work. You might direct a team to get the new standard work to a level 2 by the end of the day. This is still a work in progress, and we have several PDSAs and tests underway with various work streams across the organization. We also refreshed our standard worksheet, or otherwise known as spaghetti diagram, by asking users to not just call out where quality or safety checks occur, but where inequities may appear. We call them out by using the infinity symbol. We ask our leaders and team members to not only capture what they see, but also capture where the opportunities for inequities may exist. Our time observation form got a facelift as well, and we carved out a section devoted to capturing stories. We wanted to be better about incorporating qualitative data into our tools, something that the event team noticed was a weakness in our methods. Here is a real life in the wild example of how we might use these symbols in our standard worksheet. This was used on an event in building our Respect for People workshop standard process. The equity symbol, again, the infinity sign, is used here, and you can see them highlighted in yellow. And these were placed in areas to depict where the process had potential equity impact. In this standard worksheet, all the workshop elements denoted with numbers, so they all had steps. So all the steps except steps 1, 4, and 5 had a potential equity impact related to the participant's experience. For example, we do a discussion activity following a video that displays bigoted behavior from a patient. The potential equity impact of this video and subsequent discussion is documented with the equity symbols next to steps 6 and 7. Here is an example related to our value stream map, where equity cloudbursts are highlighted in blue. Stakeholder feelings associated with each cycle are an example of the impact the equity issues have on them, we can see in hearts. These wastes can either be observed in person or be a known equity pain point. So I'd like to quickly go over 2 examples of how this systematized focus on inequities has improved our processes for our patients and for our team members. Our kidney transplant team wanted to trial these new tools. The nurse manager of the department held multiple equity pauses in various settings with the following results. I'm going to tell 2 stories. So the first thing that, let's take a look at our transplant eligibility before we did the equity pause series, before Scott did that. The potential recipients, they need to meet medical, surgical, and financial and psychosocial criteria to become eligible for kidney transplants. One of the medical requirements is for each recipient to go to the dentist and have a licensed dentist sign a clearance form stating that the patient has no active infections. In general, we assume that people go to the dentist twice a year, so no big deal. It should be pretty easy to get that clearance, right? Well, they started doing some research, and they found things like 117 of our delayed or inactive patients have no dental insurance, have no dental clearance on file, which is 34% of our patient list. 66.7 million Americans don't have dental insurance at all. 70% of seniors age 65 and older also don't have dental insurance. 45% of Americans have 0 savings. And when families can't afford dental care, they skip it. And finally, there are 0 regulations that require dental clearance prior to a transplant. After reviewing with our transplant quality manager, medical director, and leadership team, it was clear that dental clearance posed an inequitable barrier to transplant to those who could not afford dental insurance or visits. So thanks to the equity pauses, dental clearance was removed from the transplant recipient requirements. Another problem the manager tackled using equity pauses was to update a blood chemistry test. I have a lab background, so I hope you don't mind that I take just a minute here to get technical here as I explain. This is an image of a lab results page from our electronic medical record system. Estimated glomerular filtration rate, or EGFR, is a blood test that is an indicator of kidney function. In order to start your wait time for transplant, you must have an EGFR of less than 20. Well, the problem is EGFR is calculated differently for Black people, causing their EGFR levels to be higher, thus causing a delay in reaching that important 20 mark. In a recent study, it was found that without the use of this race-based calculation, up to 1 out of every 3 Black patients would be reclassified as having a more severe stage of chronic kidney disease. And up to 1/4 of Black patients would have been reclassified from stage 3 to stage 4 of the disease, the final stage before kidney failure, which can trigger more advanced care. Other institutions like University of Washington, Mass General Brigham, Vanderbilt, and a growing number of other institutions have abandoned the use of this calculation altogether. So you're probably asking how this happened in the first place and why it's been around for so long. The coefficient was applied to statistically adjust for differences in muscle mass in Black persons, which may not apply to all Black persons and is based on old racist science. Race is a complex social construct and is distinct from biological variables such as ancestry. And furthermore, definitions of race may be subject to significant bias because race may be self-reported or assigned by a clinician or observer. An inclusion of the race coefficient and these equations contributed to health disparities, including eligibility for kidney transplant, which uses a strict EGFR cutoff. After several equity pauses and connections with lab leadership and clinical leadership, the race-based blood test is removed from the transplant recipient requirement so that we can better support Black patients to transplant. The nurse manager used both spontaneous and the planned equity pauses to get whole teams to look at these long accepted practices.
All right, thank you, Shauna. So these are just 2 really great examples of how frontline team members were able to point out inequities using our tools and then design processes to dismantle those inequities and create more access for our patients. I just want to take the next 5 minutes or so to really start thinking about how you can start looking at your lean processes with an equity lens. So one of the things that I think is paramount to looking at your management system is by getting the support of your executives. We would not be where we're at today if it wasn't for our president and for our senior leadership to say, yes, tell us what we need to do to start incorporating the equity lens and we will support it. And this was something that was essential to creating that safe space for our team members, knowing that our executives was giving us the agency to do that. So in your organization, be thinking about who your leaders are and who you can leverage to help champion this work, to help role model what does this look like, and to help remove barriers. I believe this work would not have been successful if we did not use our tried and true tools. So in a way, we really did struggle with this event because we were having to utilize this process that we were starting to find was super problematic in order to create solutions that would address the process. And I think just using what works for you in terms of change management and process improvement to do that work helps facilitate the process improvement. In addition, one of the things that we felt was super important when we're going into this work, and also I think is important for you, is that in order for you to be really successful in incorporating an equity lens, systematizing an equity lens, you want to start with what you already use, what your processes already are, because we felt that if you created additional tools or additional toolkit, it would be easier for leaders and team members to I don't want to say intentionally opt out, but to overlook or to not utilize that tool because they already have a process that they're familiar with. So what better way of systematizing equity by building it into the tools that we already use, like the standard worksheet that Shauna showed you earlier. So that tool is already out and leaders are using it already at capturing inequities in the process. As I mentioned earlier, our management system impacts everybody. So it was really important for us to really think about how we were engaging them and how we were getting their input. And it was actually through conversations with our frontline team members that we started to realize how problematic our management system was. We didn't realize how exclusive it was for many of them until we started to engage them in the dialogue. And I truly believe that many of our frontline team members know these inequities more than the leaders, or more than the continuous improvement specialists that we are. And so engage your frontline team members, engage your executives, bring everybody to the table and have that dialogue. In addition, I would start challenging you to think about who in your community can help you with this work. Are you working on a process that involves a unique customer population? Why don't you reach out and see if there's any community organizations that deal specifically with that customer population and find out what works best for them. So you have a wealth of information and knowledge out there in the community. And so I would say, break those silos, invite the community to the table as well. When we were doing this work, we came across a lot of mental valleys or assumptions around the idea of diversity, equity, and inclusion work and lean being mutually exclusive. I'm here to say that is not the case. We can find a marriage between the two. Another assumption that came across often during this work was, well, yes, it makes sense to incorporate equity lens for processes that impact the patient. Well, inequities are everywhere, just like waste. And so we need to start training our eyes to look for those inequities. Yes, there might be inequities in how we handle patient populations or in the clinic, but there's going to be inequities in human resources. I saw many of you chatted that recruiting was an opportunity for you. So there's inequities in human resources. There are inequities in IT. There's inequities in every department. So you just got to start training your eye to see those inequities. And that's why we have the handout that you guys can take with you. Just 3 quick kind of takeaways that Shauna and I had around this work is that our management system promotes going fast. We love speed. It gets us to evolve quicker. But how do you balance speed when you're talking about things like racism or sexism? And so that was a real challenge that we had. And that's why the equity pause is so powerful, because you are able to force that pause, step back and reflect. I really check in. Are we going too fast? Do I need to pull off the accelerator? I think it's also important for us to be thinking about extending grace to everybody on their equity journey. We're all in different places in our understanding of DEI. And so we need to really accept and recognize that we're all in different places and work together to move and to evolve together. And we're all human. You're all going to make mistakes, and that's okay. And it's okay to not know. That's why, Shauna mentioned earlier, with the equity pause, just do it. Just say, let's just pause. I'm not sure. Is there an inequity here? But tell me, do you see anything? Because somebody's going to see something that you haven't caught. And then lastly, you want to keep the fire going. So this is not a one and done project. This event that we had, it was called Systematizing Equity into VMPS number 1, which was telling and a symbol of the fact that this was just the beginning of our journey to systematize equity in our management system. You saw those opportunities on the fishbone, all those red stickies. We only got to maybe a 4th of them in our events. We have much more work to do. And we also have other aspects of our management system to look at. One of the next focuses for the next quarter and the next year is going to be looking at how we do dealing management and embed equity in there. But if you have any ideas, feel free to put them in the chat, because we can probably start using some of them now. So that is our presentation. Thank you for joining us and kind of hearing our story. And I see we have some couple questions.
Yes, there's a question here that says, when were the race-based tools removed? This was done in the spring. I think this is what we're talking about for the blood test, for instance. Yeah, the EGFR, that was in the spring, this spring. We're a little bit behind the times.
Something also say is that once we moved it from transplant, we then removed it from the entire organization. So the organization no longer uses that practice.
Someone asks, do you find that these tools and resources are being utilized outside formalized improvement work, the equity pauses and the waste wheel?
So we are finding that, yes, these tools are being used outside formalized improvement work, especially the equity pause toolkit. I think leaders are, so our management system is really all aspects of work, even outside in workshops and whatnot. And our leaders are, they've been hungry to try to apply an equity lens or apply equity to their work, but just don't know how. And so even just having these tools out has been immensely helpful for many of them to take and just look at their own processes, even if they're not doing a Kaizen event. But also look at their team dynamics. And so to answer that question, there's been a lot of usage of the tools outside of these formalized formal workshops because of the desire to really better understand their work with an equity lens.
Someone asks here that they're curious, did the mortality and complications go down or is it too soon? And I don't actually know that number, but it's a good question. I don't know that answer. It's a good question. Let's see here, something about the handout missing a few pages. I'm gonna have to see if we can get those.
I think we can work with Results Washington, just make sure that you guys have the right document. So the document that you should be seeing is the waste wheel.
Okay, and then here's a great question. Did you experience any internal pushback? And if so, how did you overcome it? My answer is yes, and we are still experiencing it. I feel like, with our position, Nate and I are kind of in unique positions. We get to be creative and try new things and weird things all the time. But we're still getting some pushback, but we're just, we demonstrate it. And we really, I think that one of the keys is another type of pushback that we got is that people were scared. They were hesitant to try it. And I just had to convince, me personally, I would convince them it's just about facilitating, right? You don't have to know all the things. So just facilitate it. Start it with either like an exercise or a question. And the team usually just takes over from there. And I got to be honest, any team that I've seen this practiced with has just been so happy and really engaged with the discussions and the pauses. And they're just really excited to see that we actually have a tool and we're trying to do something about this. So would you have anything to add to that, Nate?
I would just say that any pushback that we've gotten, I mean, a lot of it is what Shauna has mentioned, but oftentimes one thing I find that's really helpful is tying it back to the patient, because that's what we're here to do at the end of the day. It's not about you or me, it's about serving our customers and framing it in a way that helps them understand how by building or redesigning our processes to better accommodate the patient, we can serve our patients better. I think that has been a really effective form of persuasion. I will just comment, I'm looking at Perla's comments and I 100% agree. I think that's something that we struggle with is how do we not co-opt or inflict emotional burden on our team members and our others, the community member partners. I think that's something that it's kind of an ongoing struggle. We'll have to kind of really be careful of, but I 100% agree.
Yeah, I think some of the complications that we've had in the past is, before we combined with CHI, we were just a small not-for-profit. And so it was really hard. We have a very small amount of money to donate and stuff, but we still were able to do some. So it's good. But yeah, it's really important.
So I'm hearing more questions about EGFR. Both Sean and I are not clinical, so can't really tell you like all the clinical details about it. But in terms of, I know that yes, the healthcare industry large is moving in that direction of getting rid of the EGFR. My understanding is that we're not the first organization to do it, and so I think we're moving in that direction.
Yeah, if you'd like some more technical information around with our transplants and our nephrology systems, they're always open and willing to chat with someone about it. So, you can just look us up on our website, look at Kidney Transplant Nephrology Departments at Virginia Mason. And Scott Ox is the manager there who led that work. And he is a wonderful nurse leader who's very talented. So he would be a good one to talk to.
Do we have time for one more question, Jessica?
Unfortunately, we don't. We are quickly approaching the end of the hour. Thank you so much, Shauna and Nate, for sharing all the amazing work that you've done. Clearly, it's impressive, and we're really grateful for you sharing the inequity wheel with everyone who's here today. Thanks to everyone for attending. We've got 2 more sessions today, so if you're not signed up for those and have time and would like to, go out to our website, sign up for those 2 sessions. You can also find materials from all the presentations so far, and videos will be up within about a week or so. Thanks so much for your time. Again, the survey will pop up at the end. Please take the time to complete that. Give us and Shauna and Nate some great feedback. Thank you so much, everyone. Take care.